And I'm Kyu Chul Noh from Seoul, Korea. I'm Hallym University. I'd like to talk about the effect of the arthroscope guided suprascapular nerve block within the first 72 hours after arthroscope rotator cuff repair. There are so many types of regional blocks for pain control after arthroscopic shoulder surgery. The study began with the question of what is the most optimal regional block for postoperative pain control after rotator cuff surgery. A system review comparing the single-shot interscalene block to control group, it's clear that the controlling pain is effective up to 8 hours after surgery, but rebound pain can occur at 24 hours after surgery. In my previous paper in arthroscope in 2016, I found that single-shot interscalene block was effective in controlling postoperative pain at 6 to 8 hours compared to the control group. But like the previous paper, there was rebound pain at 18-hour surgery, while continuous interscalene block provide very effective pain control, but there are some potential major complications, including the need of an anesthesiologist. My concept, what are the most important factors when considering postoperative pain control after rotator cuff repair? It must be effective, safe, reproducible, and easy procedure. In addition, there should be no rebound pain, and which we talked about earlier, it should be able to be performed during the surgery by the surgeon, which is called a surgeon self-control except anesthesiologist. When comparing the suprascapular nerve blocks to interscalene block, in 2017, meta-analysis article found no significant difference in pain control. But suprascapular nerve block has less block-related complication and respiratory complication. Based on some references, suprascapular nerve block has a similar pain control effect as interscalene nerve block, and it is more peripheral location and has a lower complication rate. And the suprascapular nerve is an important part of cuff pathology. Therefore, we started by targeting the suprascapular nerve and decided to perform an arthroscopy-guided suprascapular nerve block with a single shot and a continuous block with a catheter pump, which can have both the advantage of the rebound pain reduction and the surgeon self-control. So we plan to evaluate the effect of arthroscope-guided suprascapular nerve block with the indwelling catheter within the first 72 hours arthroscopic cuff repair. From 2016 to 2018, 96 patients among 181 rotator cuff with medium to large cuff tail size were studied. It was a prospective randomized allocated study with 3 groups, which are suprascapular nerve block with a catheter pump group and ultrasound-guided single interscalene block group and general anesthesia only groups. Inclusion and exclusion criteria are below. Of the 96 subjects, 2 were excluded and group 1 to 3 were assigned, 31, 32, and 31 cases respectively. The patients were randomly assigned and the block randomization was performed and the group were matched 1-to-1. This is the detailed table of the regional blocks regimen, group 1, 2, 3. Suprascapular nerve block with indwelling catheter was performed as follows. Mainly using the Navier's portal as the working portal, the conoid ligament is located and the transverse scapular ligament on the medial side of that is identified and released. After that, 18-gauge spinal needle for a single bolus is inserted and the catheter is placed next to it to prepare for continuous block. For pain bar score, it was checked at 6 a.m. on the day of the surgery, 1 hour post-op, 8 hours, 16 hours, 24 hours, and then every hour for the first 72 hours. The rebound pain was defined as an increase in the bar score from the 1 hour pain bar score. Standard protocol was oral painkiller twice a day, and IV tramadol was injected if bar score was more than 6. And postoperative complication was checked for motor sensory abnormality, tingling sensation, nausea, vomiting, and infection. The total sample size is 93 cases. The statistics are as follows. The statistical power of the 90%, p-value of 0.05, effect size of the 0.9, drum rate of 5%. Demographic data shows that there is no significant difference between the three groups. In pain bar scores, the suprascapular nerve block with the catheter pump had the lowest rebound pain. And as you can see in the graph, the overall pain bar score was the lowest among the three groups, and it was statistically significant. Furthermore, if you look at the number of the rescue analgesic injection, we can see that suprascapular nerve block catheter block is the lowest among the three groups. Looking at the characteristic rebound pain, we can see that group 1 has a shorter duration and a lower maximum bar score compared to the group 2. Through the multivariate regression analysis, we can see that single interscalene block was 3.73 times more likely to cause rebound pain than block with the suprascapular block. So if you get the complication of the suprascapular catheter, there is no major complications. My concept is that dual suprascapular nerve block is the optimal for postoperative pain control after cup surgery. Single suprascapular nerve block will be immediately effective pain control, and consecutively continuous block will be controlling the rebound pain. Atherosclerotic suprascapular dual block is the first study about the regional block for pain control of the cup surgery. Dual block can be said to reduce the rebound pain through a soft landing effect. The difference of duration of below dual blocks might lead to soft landing effect, which could decrease of rebound of pain. Limitation include a relatively small sample size. The study design was prospective, but not completely blinded to block type, and the administration of rescue tramadol may be obscured the actual amount of postoperative pain. Suprascapular nerve bolus block with indwelling catheter reduce pain in the first 72 hours after rotator repair and attenuate the rebound pain. Second, arthroscopically guided dual suprascapular nerve block is feasible for the operator without anesthesiologist intervention, which shows that it's effective and can be a safe alternative to interscalene block after arthroscopic shoulder surgery. Thank you for your attention.